Michael?
Yes. Can you hear me?
Yep.
Okay.
Okay, remember we're talking about inflammatory disease of the foot and ankle. So what do you see here?
Okay, so we see a lot of soft tissue swelling overlying the lateral malleolus. In that region, I think for the conceive the fibula, it looks, I don't see anything definitely affecting the bone. So we can, we can still see there's kind of a lot of soft tissue density surrounding that, the ankle joint. I'm wondering if there's like an effusion or synovial thickening. So what we have going on here, I mean, this looks like a, from the single cut, this almost looks like we have like, severe advanced lateral hindfoot impingement.
Okay, if we go back, it's not that easy to see on the plain film.
Yeah, I was wondering that oblique, but, because you have impingement between the distal fibula and the calcaneus laterally and like a hindfoot valgus.
Maybe. But a little bit easier to see on the MR. So you can actually see that there's eburnation and direct articulation between the fibula and the calcaneus with valgus deformity of the calcaneus.
Yeah, pretty much. And this is going to be from lateral impingement, probably from acquired flat foot deformity.
Yeah, absolutely. Yep. Okay, here's some other images of the same patient.
So what we're seeing here is you see there's edema and eburnation in that lateral talar process. And then now you're also showing that there's, large effusions or synovitis.
Right. Yeah, big effusions.
The head is missing, isn't it?
The what?
The head of the
I think it's just the cut. I think it's just the angulation and location of the cut, John. But that's a good point. But I think that was just it. Here are the axial images. What do you think of these, Michael?
So we have severe tenosynovitis of the peroneal tendons, probably with a split tear of the brevis. There's some fluid, it looks like, in the posterior tibialis tendon as well. So there might be some synovitis. And then, just kind of right there posterior to the tibia where you're circling, there's just kind of some diffuse kind of pericapsular joint synovial thickening, and then some edema involving the extensors as well. So it's just kind of, there's diffuse kind of tenosynovitis affecting multiple tendons.
Yeah.
And so when you see this much tenosynovitis, you got to think of an inflammatory arthropathy or some weird infection or some like abnormal type infection.
Right, and this was chronic rheumatoid arthritis with extensive tenosynovitis that had gone on to developing an adult acquired flat foot deformity and all the lateral impingement that you saw. Right. So we hope not to see this anymore, since this can all be treatable before. Okay, Ashley, what do you think of this one?
Looking here, almost looks like there is a mass between the third and fourth metatarsal heads there. Has a heterogeneous T2 signal, low T1 signal. First thing you think about is a Morton neuroma in this location. And there's another one between the first and second metatarsals. There's a little bit of erosion, actually. Yeah, there's a little bit of erosion of that third metatarsal. This might be a mimic. Oh, yeah.
Yeah, so this is
the rheumatoid nodule.
But it looks very, these are all rheumatoid nodules. And so really, it's really synovial thickening within the bursa between the metatarsal heads. And but it kind of mimics Morton's neuromas.
Do you ever get an erosion in Morton's neuroma?
I've never seen one. That doesn't mean that they don't occur, but I've never seen one.
I've operated on a lot of them. I've never seen one either.
Yeah. Okay, Jennifer.
Okay. So here we have some sagittal MRI images of the foot, and there's a nodular soft tissue signal intensity mass kind of along that MTP joint. This could be a rheumatoid nodule related to rheumatoid arthritis. Here again, we see some surrounding peripheral enhancement on post-contrast images, and it's on the 5th MTP joint, so most likely this is a rheumatoid nodule.
Yeah, right. Okay, right. Yeah, and that was a rheumatoid nodule. It looks a lot like a pressure lesion in a case like this. Okay, Ashu. Or actually, I'm sorry, Michael, I think you're next.
Yeah. So first thing is severe degenerative changes of the talar-navicular joint. There's extensive amount of edema throughout the talus and the navicular, the bone-to-bone articulation. There's joint effusion with probably synovitis as well. Just the amount of edema, I mean, it looks like it's more than just like, normal degenerative changes. Where like there's like, I don't know if there's some component of osteitis and inflammatory arthropathy with secondary osteoarthritis degenerative changes.
If you notice the orientation of the talus is
it's pretty
vertical.
It's pretty steep, which you can see in like a hindfoot valgus type deformity.
Yeah, it's flexed with respect to the other bones here, and this degenerative disease of the talar-navicular joint, as you said.
I would call it a little vertical.
Yeah.
Yeah.
And
then, so of course, you do want to look at the PTT integrity. And so I guess we're showing like an osteochondral lesion of the navicular.
Yeah. And so this patient had rheumatoid arthritis, had tenosynovitis, chronic tenosynovitis, loss of function of the posterior tibialis tendon, and then went on to develop adult acquired flat foot deformity.
Yeah.
Good. Okay, Ashu.
Looking again, there's a large ankle effusion. It looks like a lot of synovial thickening here. There's marrow edema of the talus. There's some, I don't know if there's some early erosive changes along the distal talar neck as well, and some cystic change there. I'd be worried about rheumatoid arthropathy or another inflammatory arthropathy.
Yeah, a lot of synovial thickening here. And this is synovitis and rheumatoid arthritis. Okay, Jennifer.
Okay, so here we have two sagittal images of the hindfoot, and there is effacement and edema within the sinus tarsi, and looks like severe degenerative disease of that subtalar joint with erosions surrounding the sinus tarsi and severe subtalar joint degenerative disease. There's a large joint effusion. Could be some mild synovial thickening. This could also be an inflammatory arthritis.
Yeah, this is one of the causes of sinus tarsi syndrome is rheumatoid arthritis, and this is sinus tarsi syndrome and rheumatoid arthritis, where you have a lot of synovitis involving the sinus tarsi, and they then develop instability, which leads to the syndrome. All this degenerative disease from the instability. Okay, Michael, a little subtle case here.
Okay, yeah, so this looks like it's kind of similar to what I had seen on the prior one, except to a much more advanced and severe degree with, if they've had inflammatory arthropathy leading to acquired flat foot and then just severe progression of the hindfoot impingement. I mean, there's like when you see on this axial image, the talus and calcaneus aren't even like aligned at all. They're completely subluxed to each other. Right. So it's like a, that it's just completely, like I said, subluxed and
they're side by side rather than
laterally.
Right. So that's marked destruction and extensive instability of the talar-navicular joint space. Right. And then here's more of the same, where you can see extensive destruction of that talar-navicular joint space and subtalar disease and rheumatoid arthritis. Okay, Ashu.
I think this is a dislocation. It's hard to tell, but I don't think that metatarsal is articulating with that phalanx. So
So one of the things that occurs both in the hands and feet with rheumatoid arthritis, with chronic rheumatoid arthritis, the capsular ligaments in the capsule become degenerative and stretch, and you get instability. This is most common in the metacarpal phalangeal joints, where you get a very characteristic volar proximal displacement of the proximal phalanges with respect to the metacarpals and rheumatoid arthritis. But you can get instability and dislocations in any of these small joints of the hands and feet in rheumatoid arthritis due to that.
The synovitis just stretches all the ligaments out.
Yeah.
And tendons get degenerated and
right.
Damaged, obviously. And then you get dislocations, etc.
Jennifer, what do you think of this one?
We try to repair a lot of them. Usually you wind up amputating.
So here we can see medial dislocation of the great toe proximal phalanx with respect to the metatarsal head. And there's surrounding soft tissue thickening, probably chronic synovial thickening and synovitis. I guess this could be inflammatory arthritis or it could be gout. There may be some osseous erosions there along the plantar aspect of the metatarsal. And here we can see lateral subluxation of the sesamoids.
So this is a chronic metatarsal tarsal dislocation, another patient with rheumatoid arthritis.
And gout doesn't usually do that.
Yeah.
If you go to that, oh, sorry. That first image, I thought there was polydactyly.
Right. Right. Because you got lateral dislocation of the toes with respect to the metacarpal, first metacarpal there.
I can assure you that this foot is very, very painful. Yeah. And what would one of our fellows do to treat it?
Probably be difficult to find appropriate footwear too.
That's correct. You cannot find it. To come to the chase, what we do is called a Clayton procedure. You excise all the metatarsal heads, and that takes away the pain in most cases, and the footwear becomes easier to wear. It's interesting that amputation would be so helpful, but it's a very, very effective procedure in cases where you cannot do anything else.
Great. Thank you, John. Okay, and then here we can see also lateral displacement of the sesamoid bones, also in a patient with rheumatoid arthritis. Okay. Michael,
is that a common thing you see?
Yeah, you can get, again, it has to do with this changing of the integrity of the capsule and tendons and ligaments. They become stretched, and so it's easy to get anything in these small hands and feet dislocating because of chronic rheumatoid arthritis. Again, hopefully, with modern therapy, we won't see that very much.
Okay. All right, so we have a coronal and axial ankle. So it looks like there's probably, I think, a lot of fluid and synovial thickening involving the perineal tendons as well as fluid within the extensor tendons. I think is what you're trying to show me, unless that's just.
That's fine. That's not what I was trying to show you, but that may be that may well be.
I'm not sure if that's actually muscle or if that's actually synovial thickening right there of the perineal brevis.
Yeah,
but
what about the bones?
The bones are abnormal because they are there's bony bridging between the tibia and the fibula.
Yeah, so we can see fusion in rheumatoid arthritis, and I think we already talked about the mechanism that causes the fusion, right? Okay, Ashu.
Looks like there's another fusion here between the talus and the calcaneus in this 54-year-old female with RA, rheumatoid arthritis. And you can see the fusion better on the sagittal images. There might even be fusion of the talonavicular joint here.
There is, yeah. I think I'd prefer these fusions than the severe destructive disease that we saw in some of those others. Yeah, but here, extensive fusion.
Self-induced triple arthrodesis.
Right, yeah. Okay, Jennifer.
Okay, so here we have some images of the midfoot, and it looks like there is some solid osseous bridging or fusion between the navicular and medial cuneiform.
Yep.
So I guess this is another fusion.
Right, good. Okay, Michael.
So what is their history?
Rheumatoid arthritis and foot pain.
Okay. I mean, there's a lot of bony abnormality going on. I mean, right there, if you look at the lateral, like, where you're pointing out, there's fusion and there's extensive destruction and remodeling of the TMT joints. Just extensive fusion and remodeling and abnormal configuration.
Yeah. And of course, whenever you have fusions like this, it changes the whole force pattern in the foot, which can lead to pain in and of itself.
What I always found interesting is that you name a position of a bone in a foot or hand or whatever in rheumatoid arthritis, and you'll find all kinds of different defects.
Yeah.
It's amazing. It's like what this disease can do, and everything that it does is miserable.
Yeah, right. Ashu, what do you think of this one?
46-year-old male with history of rheumatoid arthritis, chronic right second toe pain for 6 months following surgery, excised periarticular calcification, post-op course complicated by significant tissue ischemia and local sepsis. All right, so pre-op versus post-op, we can see a lot of soft tissue calcification within the pre-op film surrounding the second digit. In the post-op, you can see that there's a lot of it's been resected. I think they also resected the middle phalanx. There is a little bit of calcification there too. There's a little bit of dislocation. And here we're looking at the soft tissue calcification also near the calcaneus, posterior heel, right there. Pre and post-op, the soft tissue calcification at the second digit has definitely improved. There's more calcification at the heel on the post-op film. Interstitial fibrosis, I guess, is the diagnosis here. Hard to tell. A lot of soft tissue calcification near the greater trochanters, maybe the gluteal insertions there.
So the patient's thought to have rheumatoid arthritis, but then you've got interstitial edema of the lungs and then all these calcifications.
A lot of calcifications, and looks like there's a lot of, I don't know if that's a fracture or if that's just soft tissue osteitis of that phalanx, distal portion of the phalanx there. It's enhancing. I don't know if this is post-op. Could you get an infection? Oh yeah, they got a sepsis, right? They got a localized sepsis.
Right. Yeah. So that's right.
A lot of soft tissue calcification and rheumatoid arthritis. Crest syndrome, right? Okay.
Yeah, this is the Crest syndrome. Calcinosis, Raynaud's phenomena, esophageal dysmotility, sclerodactyly, telangiectasia, and it's really part of scleroderma. Yeah, unfortunately, there's no way to really treat this. Okay, Jennifer.
Okay, so here we're looking at the forefoot, and we can see edema and osseous erosion within the second digit proximal phalanx, and there's also a joint effusion present. I guess this could be infectious or inflammatory depending on the history. Here we can see more of the joint effusion and also another osseous erosion in the metatarsal head, and looks like also a first MTP effusion.
Yeah.
Psoriatic arthritis.
Yeah, let me see if we go back here. So we're getting a lot of soft tissue edema within the digit. Now with psoriatic arthritis, you typically get more peripheral disease, but you can get metatarsal phalangeal and metacarpal phalangeal disease and psoriatic as well. But the characteristic thing is the soft tissue edema within one digit called dactylitis, which is pretty characteristic of just psoriatic arthritis. So this is psoriatic dactylitis. And on the coronal images, we can see all that inflammatory disease around the second digit there. And here we can see it coming out. A lot of inflammatory disease around one ray here, and that's pretty characteristic of psoriatic arthritis. I'm not sure, except for local infection, I don't know of anything else that kind of looks that way. So you always have to be concerned about a cellulitis when you see this. Okay, Michael? Michael, you still with us?
Sorry, I was talking. My mic was off. There's soft tissue edema and bone marrow edema involving that second phalanx, and I believe that's involving that the joint as well. That's not volume averaging, correct?
Correct.
Yeah. So.
There are the coronal images.
So on the coronal images that we can see, the extent of just kind of diffuse extensive soft tissue edema. It actually on the coronal, the bone actually looks it looks cleaner.
Right.
I don't see, at least on that cut, I don't see definite bony edema. Neither do I on the sagittals. So kind of just diffuse. Like if this is a sausage digit, you got to think of like psoriatic arthritis.
Yeah, so this is another.
Or it could just be infection, cellulitis too.
Yeah, those are the two things you need to think about. And in this particular setting, this was psoriatic arthritis, another dactylitis.
With infection, and you don't really see that, do you? There.
Say that again, John.
With infection, you deal with pus.
Yeah. If you see something that you know is an abscess, then you're absolutely right, John. You've got to really think about infection rather than a psoriatic dactylitis. Absolutely, you should not see a big fluid collection and psoriatic dactylitis. It's just diffuse soft tissue swelling, right? Okay, Ashu.
All right, so 23-year-old male with low back pain and ankle pain. On the radiograph, sagittal imaging, I can see some spraying at the posterior calcaneus. I don't know if that's some traction changes at the Achilles tendon insertion. On the STIR imaging, you can see significant edema throughout the posterior calcaneal margin. It looks kind of irregular. Doesn't look normal. And there's a small retrocalcaneal bursal effusion as well.
Okay, so what are you thinking of here?
So
you got some osteitis here, and you've got osteitis there, but it's
I think there is osteitis basically.
Low back.
Primarily at insertions.
At the insertion, the insertional,
You get a little tip when it says back and ankle pain, don't you?
Oh, is this ankylosing spondylitis?
Well, that's a possibility, isn't it?
Yeah, because there's actually fusion here. There's ankylosis of the medial cuneiform navicular and fusion there, osseous fusion. So, yeah. Okay.
Right. Good. Okay, Jennifer.
Okay, so here we see erosive changes at the medial aspect of the first metatarsal head and also erosions along the distal aspects of the proximal phalanx. This could be, and other erosions throughout the other metatarsals. I guess this could be gout, or it could be erosive osteoarthritis.
Yeah, yeah. Notice that what we see of the joint space looks pretty normal.
Yes.
We just see these erosions, and this was gout.
Okay.
Yeah, and you can see all this soft tissue thickening here with relatively sharp margins. The one thing with gout, if you have an acute disease with rheumatoid arthritis, the margins are usually indistinct because you've got a lot of osteitis associated with them. With gout, the margins tend to be very sharp, and you kind of get these sharp spicules that you're all familiar with, which is very characteristic of gout. Other inflammatory diseases, they kind of dissolve the bone, and you don't have these sharp prominences. With gout, you get these sharp little spicules of bone that you really don't get in anything else. Kind of sharp margins. So this is gout. Michael.
Okay, so in that first digit IP joint, we see significant erosive marginal erosions along the joint with significant like synovial pannus extending into it. So it's kind of similar. And to Jennifer's case, that this could be gout.
Again, you see these sharp little spicules here. And notice how sharply defined this is with these little sharp little spicules that aren't flattened out.
Yeah.
And again, this is
That's
characteristic
kind of
of gout.
classic, isn't it? Yeah, the great toe.
Right, and the great toe is the classic place, absolutely. Ashu.
So 47-year-old with big toe pain. Again, a lot of osteitis of that distal first metatarsal. There might even be erosion along the medial aspect right there, and maybe a small spicule kind of anterior. So this could be gout as well.
Yep. Okay, Jennifer.
Okay, so 61-year-old male with a palpable mass. We can see a large soft tissue signal intensity mass that's increased on STIR images, kind of throughout the first metatarsal, head and neck. This could be like tophaceous gout with osseous destruction.
Extensive destruction there of that first metatarsal head. Oops. Yeah, same patient. There's the MRI. Here are the plain films. This really looks like infection here. That looks like it could be a very acute osteomyelitis, but you've got these spicules of bone, which generally with infection, you're not going to have these little spicules of bone like this. And over here, and this is another case of gout. Okay, Michael.
Okay, so dual energy CT case, red swollen medial left ankle, treated for cellulitis, no response. Strain ultrasound, soft tissue swelling, suggestion of soft tissue mineralization, crystal deposition. Color coded for uric acid crystals, green, shows definite gouty tophus.
Okay, so here's the case. I shouldn't have shown that. The answer to begin. Sorry about that.
So you see this marked soft tissue swelling overlying that lateral malleolus. So we kind of see this soft tissue, like heterogeneous mass right there. It does have some echogenicity within it, which is, I guess, assume is the mineralization. And then here's the dual energy, which is showing the uric acid crystals.
Yeah. Yeah, there have been a number
of big, gouty tophus type thing.
Right. There have been several papers that are published where they've used CT and see if it improves the outcome and diagnosis of gout and the management and so forth. And most of those papers have said that it's not very useful. But occasionally, if there's a concern, I think doing dual energy CT can be helpful in helping establish that you do have uric acid crystals and making the diagnosis in questionable cases that aren't obvious from the clinical and other imaging findings. So this just shows how you can use dual energy CT to help with the diagnosis. Okay, Ashu, patient with ankle pain.
Not quite sure. There's some eburnation there along the anterior calcaneal margin. And, there's a lot of soft tissue edema along the lateral aspect. The ankle, the peroneal tendons look maybe a little synovial thickening there. And then also the anterior extensor tendons, I guess. There's some soft tissue thickening. Is that just tophus? Some osteitis of the medial malleolus, and there's a lot of soft tissue abnormality with contrast enhancement along the lateral aspect of the ankle.
Yes, they kind of lost it, not a lack of enhancement centrally there. Here again, we can see this large kind of mass in the soft
and
tissue.
It's following,
and this was
gout case.
Big gouty tophus. Okay. Jennifer.
Okay. So here we have two axial images of the ankle, and there's soft tissue signal intensity kind of filling the flexor hallucis longus tendon sheath and the flexor digitorum tendon sheath. There's a lot of soft tissue and also increased fluid signal within the hallucis. So this could also be a tophus deposition seen with gout along those flexor tendons, and there's some surrounding soft tissue edema.
Yeah, so you often can have bony erosions at typically the insertion of ligaments and tendons. But another thing that you can get with gout is just tendinopathy, where you get uric acid crystals depositing in the synovium of the tendon sheaths. And this is what that looks like. So here we don't see bone erosions, but this just shows you the tendinopathy that you can see in gout. It's less common than the bone involvement, but it can be difficult. This is obviously very chronic because these are very large, and sometimes the diagnosis is delayed because people don't think about it. Okay. Michael.
Okay, so we have a huge heterogeneous like mass or thing of synovial thickening surrounding this Achilles tendon, which could be the similar finding to the previous case or similar pathology, I mean.
Yeah, this is all gouty tendinopathy involving the Achilles. It's amazing to think that they can get that big.
John,
what, John?
Would that be tophus that Jennifer was talking about?
I don't know that I'd call these tophi.
Tophus usually in it.
I'd call this gouty tendinosynovitis, I think.
Doesn't that involve the skin there, John?
Involve the skin? I think the skin is being displaced here, I believe.
Yeah.
It certainly goes up to the skin. But here's the deep fascia right here. So it's really pushing out the deep fascia of the skin.
When do you start calling it a tophus? When it breaks through the skin or what?
I don't think it has to break through the skin. I think a lot of people would call this tophus. I don't think it's wrong to call it tophus.
And that's what I was thinking is when you push the skin outward or you show swelling, that's a tophus.
Yeah. Well, histologically, it'd look like a tophus, so that's fine. But it's involving the synovium. Well, in this case, obviously, the Achilles doesn't have a synovium, so tophus is probably the right word to use here. Good. Okay. See, Michael, did you do the last one? I don't remember. Ashu, why don't you do this one?
Yeah.
Okay, so 39-year-old male with insertional pain. It's kind of a similar finding here, a lot less pronounced though. At the insertional Achilles tendon, there's some abnormality posteriorly, and there's a lot of edema also within the calcaneus as well. And that might be inflammatory. And there is an abnormality along the posterior aspect of the Achilles tendon, and so I'd be worried about a smaller tophus.
Yeah, again, this is Gouty Tendinopathy, again, another manifestation where here it's predominantly abnormality within the tendon itself, not quite so much the synovium and also the bone. Yeah. Jennifer.
Okay, this is a 72-year-old female with a hot swollen ankle. Rule out tear, fracture, or tenosynovitis. It does look like she has a cystic lesion in the distal tibia, but it's pretty well circumscribed. I think that may be incidental. Along the lateral tibial fibular soft tissue, she has subcutaneous edema and soft tissue thickening in the region of the peroneal tendons. She also has a large tibiotalar joint effusion. And then here we can see that joint effusion and that soft tissue thickening along the lateral ankle. To me, this doesn't point to effusion and bone infarct. Okay. So this is synovial thickening. I think they may need to aspirate it to see if it's infected. I don't see any definite signs of infection. Okay, pseudogout.
So they aspirated, and this was pseudogout, right? So what's pseudogout?
Pseudogout is calcium pyrophosphate deposition.
So you what you see in it is flecks of calcium pyrophosphate rather than uric acid, and it can also produce inflammatory disease. So there's a lot of debate about what pseudogout really is, and some people believe that the calcium pyrophosphate is just destruction of the bone that you can see in any kind of degenerative joint disease. But when it's associated with what looks like a hot inflammatory reaction from the body, then that's generally called pseudogout if you can't find any infectious agent or uric acid deposits. So this was pseudogout. Okay, Michael?
Okay, so there's like a regularity of that distal fibula and tibia, a kind of chronic appearing cortical irregularity and kind of undulation. And then looking on the hands, see similar type finding in that distal radius maybe and the distal ulna.
Right.
So yeah, the Pachydermoperiostosis.
And you could think about melanostosis, but it's usually not this diffuse, right? Yeah.
None of the bones are normal.
No.
I would be thinking about lung cancer.
Okay.
No, I don't think so.
Well, with any kind of lung disease, especially chronic lung disease, you can get a hypertrophic osteoarthropathy that probably has to do with a long period of poor oxygenation.
Usually it's the distal phalanges.
Okay. Yep.
Where you get spoon-like fingertips. That's the usual thing.
Right. Okay. Okay. All right. Let's say Achiles.
So 15-year-old surfer with foot pain and hand numbness. Looking at the first digit, you can see some marrow edema of the proximal phalanx and also the distal first metatarsal. There's also a lot of marrow edema, kind of diffusely of the phalanges. I don't know if that's a fracture or I doubt it's a fracture, but looks like just, okay, so it's just Raynaud's.
This is chronic venous phenomenon. These are all ischemic changes involving the distal extremity from the cold water, being in cold water a lot. Well, good. Okay. Well,
that's what precipitates the pain is cold water. That's one way to make a diagnosis.
Yeah, this surfer must have been very uncomfortable doing surfing. They must have really liked surfing.
Well, they wear wetsuits.
Yeah, but
so
they still had to get very cold, and this has got to be painful. This is all ischemic disease of the distal extremities. So,
well, there's always medication for these guys, you know.
Right, that's right.
They're very happy people.
Right.